Thank you for a very nice introduction to a person that I should know and a system I should know. So, well, I'm here to share, I'm honored to be here, and I'm here to share some of our knowledge. I don't have much time left, but we can do that throughout the day and the next 2-3 days. But anyhow, I'm also here to catch up things I said in the introduction to bring back home, because what we actually implemented and learned in Copenhagen and in Denmark and also in part of Europe is from you in Australia and New Zealand and from other part of the world. We just didn't invent it all ourselves, not at all. So it's all about implementing best practices, and this is what I'm going to say a few things about. You got my contact information if needed, and the presentation as well. You will get conflicts of interest. We get a lot of support from a Danish foundation and from the Lærdal Foundation, who also supported the establishment of the GRA. Otherwise, I have no conflicts of interest. A lot of Danes are actually my friends are going to Australia and New Zealand to work for a time, and some of them never return. I don't know why, but good guys. But we at least had one person coming from Australia who didn't return to Australia, and that is the Crown Princess. She had no problem in getting into Denmark without documentation and things like that. She even supported the EMS Congress in Copenhagen, and she's very, very liked by the Danish population. So thank you for sharing some experience from Tasmania in Denmark. I'm going to say a few words about the European EMS Leadership Network, which is the correspondence to the CAA. We established that as a result of the GIA, also acting on the call. What do we do? Few highlights. It's only going to be a few highlights, and then I want to emphasize the assessment tool, which is part of the GIA program that you could use, and I'll show the results from the Copenhagen system, or the Danish system. It is actually, it's not the only Copenhagen. Well, I'm not going to compare Denmark with, well, I could do that with Singapore. It's about the same population. It's bigger than Singapore in area, not much, but so it's very small compared to Australia. But when you look at Europe, which I'm going to represent here and report from, it's impossible, because Europe is not the same as the European Union. If you count the European Union, you would have 25 countries, at least for one more month, and then UK will be out. But still, in population-wise, it is about, the European Union is 500 million people. US is just 330,000. Asia is much bigger. It's 60% of the world population is 7 billion people. So the population is in Asia, actually. But it's not about size, it's about how you implement best practice. So whether you're a small country or a little country, it doesn't matter. The leadership network was established to get collaboration within Europe between the 28 different European Union countries. And we started with the Global Resuscitation Alliance, being part of that, being the representative there, and also implementing Resuscitation Academy. But it's not easy in a European Union with 28 different countries, 28 different languages. So we have the same challenges as they have in Asia, but they are doing well anyhow. The basis is actually the GRA program, the different tools there and way to measure. And we follow that systematically for the last 4 years now. And I encourage you to go to these documents, which is on the website of the Resuscitation Academy. So the European EMS Leadership Network also defined a vision to actually improve survival and quality of emergency care in Europe. So it's not about cardiac arrest, it's about emergency patient care. But cardiac arrest is a key indicator for what we are doing and how we build our system and also our culture of excellence there. So we want to implement that, and we want to impact the European Union and how EMS is organized and what is the goal there. So it's a huge ambition we have, but we are on the right track. We got people on board who is from Berlin, from Paris, from Madrid, Ireland as a whole, from Scotland as a whole, from the Netherlands as a whole, and Copenhagen is also as a whole. Denmark now, it's not just Copenhagen, and Southeast Coast Ambulance Services in UK with Fiona Moore being part of that. So that is important countries, important cities, important system, different systems that working together, and based on the common goal that we want to implement the GRA goal and the 10 steps to improve survival. And it takes a system to save a life. That's the saying we use in Europe whenever we talk improving cardiac arrest. And it becomes even more true as time goes by. The story is actually that we started in 2016, maybe a bit before, because we had the first Congress, European EMS Congress in 2016 in Copenhagen. It was in Copenhagen for 3 years. And this is not just a Congress, it's also sharing knowledge, not only within European countries, but internationally. We had about 51 different European or international countries going to that conference, and this year was the first year outside Copenhagen. It was in Madrid, and next year it's going to be in Scotland. We also have implemented the Resuscitation Academy in some of the countries in Europe, but not all of them. We're going to implement it a huge step forward in 2020 to take it to these major cities and then forward into the countries there. We organized a hackathon, also trying to use new technology to get on board. And these were not medical people being invited. It was anybody who had an idea of how you could save more lives using AEDs. And we got tremendous ideas from all over the world for people coming to Copenhagen and competing about this. And one of my guys said that when he saw one of the 3 winners there, he said, "Sorry, that was my PhD in 48 hours. And he was right. So they had no idea about cardiac arrest or the medical part of it, but they came up with new ideas and new solutions. Some of them very new, and some haven't been implemented yet, but we're still working on the 3 winners there. EMS next is going to be in Scotland. We're going to announce that within the next week. I can tell you it's going to be in Glasgow, and it's the last week of May. The Madrid conference was, I just want to mention that we share ideas within cardiac arrest and other areas as well, but the picture on the left slide, I think was the best presentation we had there. It was done by David Waters, telling about the experience of the terrorist attack in New Zealand, and it was so touching. It was so, it was really nice hearing how it affected the New Zealand community and the EMS organizations and what the rest of the world could learn from that. It was an amazing talk during that conference. How did we act on the call? First of all, the Congress is a kind of umbrella for us. We have a Resuscitation Academy program that's being facilitated in EMS organizations in Europe. We're working together with the European Resuscitation Council, but as this is all about implementation, it is within EMS and the community. We use the 10 programs to report and include in annual reports. This was an idea that turned up actually I think it was in New Zealand. So why don't we use the 10 programs to announce how far we are in implementing? And the other one was the assessment tool to monitor local progress, and I'm just going to show you. And we want to expand within the European Union our EMS approach to research as well. First of all, the Cardiac Arrest Registry. I just going to mention a few of these, and then we can discuss it throughout the day. But establish a Cardiac Arrest Registry, that's the butter and bread, as YY said. We have no common registry in Europe, not at all. We have few national registries in Sweden, Denmark, Norway, partly in the Netherlands. Otherwise, we don't have any registry. And if you can't measure, you can't improve. But many organizations, EMS organizations, are collecting data individually, and some of them are reporting these data in scientific publications, but mostly we don't know what's going on in Europe for the time being. European research publications are well known. A lot of research is coming out there, but these are research based on the best practice or the best organizations in Europe, so it's not reflecting the standard in Europe. Eureka, you might know, which is it's actually a research project. So it was a research project trying to document outcome from cardiac arrest in European countries and report that. And there's a new data coming out, but the previous one was this one. This is RUSC rate in European countries from 16. It's just 1 month of cardiac arrest in different countries. It's not even different countries, it's regions within the countries. So it's not total covering the whole of, for instance, Italy, but it's covering different countries. But the interesting part of this slide is actually the disparity in outcome. RUSC represents the EMS organization, as you can see, from 50% to about 10% RUSC rate in different European countries. Huge disparity there. Cyprus is the first one, but they delivered very little data, so the confidence interval is very big there. But Denmark and Netherlands are leading in this. And you can see that if you go to the survival rate from discharge in shockable rhythms, and this is still from 16, Netherlands is about nearly 60%, Copenhagen is nearly about 50% at that time. But you end up with countries having just a few 10% survival from shockable. New data are coming out soon. I wasn't able to get those data for this meeting. It's going to be 3 months. This time it's going to be more areas involved, and it's going to be interesting to see how much we have improved in Europe throughout that. The most important part is if you are in the low end of this, you get an opportunity, you get a chance to improve because you don't want to stay there for the next 2 years. And if you're in high end, you have to improve as well, and we all aim for the goals they have in Seattle there. So the 3 best national registries we have is in Sweden. I have had a registry for about 17 years now. These are data from 17. Survival rate increased from 4.4 to 11.4. That's all cardiac arrest. It's not the new Utstein template. But also, again, variation from 7.4 to 18% in survival rate. And you can see the increase there without the last years for cardiac arrest. So something is happening within the systems. Also, the new Norwegian registry, 30-day survival, 14%. Utstein, the new Utstein group there is actually 46% for 17. 46% for 17. That's nice. That's really nice. And Norway is a big country, 2,000 kilometers in total. A lot of EMS organizations, and now they are all working together to give these reports. From Denmark, these are 16 data. What is most interesting, you could actually see, is the 43% Utstein reportable for shockable cardiac arrests. But also that AED are being used in public places in 40% of the cardiac arrests. These are just 16 data. We are struggling with the 17 and 18. It's going to be published in next month. And the reason for struggling is that we went from a paper-based reported cardiac arrest registry to now an electronic patient chart. And what was the learning from that? First of all, it was difficult to get the data out, which is not new learning. And secondly, it was also that it appeared that we have 25% more cardiac arrest than the previous year. And we thought that would be wrong. So we went through all cardiac arrest for 2 years manually in the dispatch center and in the reports and in the hospital's report to see if this was right and if the documentation was right. And it was right. So going to electronic registration, you get 24.5% more cardiac arrests. So we are looking forward to get the final data for the outcome there, but it seems that the bystander CPR rate has increased even more. But what is most important is the outcome. We will know that very soon. And the good thing about the electronic patient chart is also that we have very few missing data in that system. In the old system, paper-based, we were missing about 10 to 15%, depending on the variables. But in the electronic one, we nearly have no misses, 2 or 3% in some of the categories there. The good thing about outcome is actually that 75 went back to work. We've seen that also since that publication from Victoria, nearly the same percentage, which is very encouraging for people who are working with cardiac arrest and in EMS, that 75% are actually going back to work. Going to the telephone CPR and ongoing training there, this is, I wouldn't call it the secret sauce as Huawei did, but it is a low-hanging fruit if you have access to dispatch centers, because you can actually stop the clock by getting bystanders to do CPR. Bystander rate in Europe varies from 60 to 78%, so there's a huge variation there. The dispatcher has a very high influence on whether there's going to be a bystander CPR rate, and the dispatcher increased the survival rate by about 200%. And if you get bystanders to do CPR, you will increase the survival rate by about 200 to 400%. AD being used, you can also, as a dispatcher, encourage people to use AD if you have an AD program, and then survival rate will be about 50 to 70%. This is all documented, and this is why the dispatcher is so important in this area. Of course, also the ambulance services, the in-hospital people, and the ICU is important, but the dispatcher is the one that makes the final outcome from the very beginning. So use dispatch to impact your survival. We do that by, we have a bystander rate of about 76%, and we worry about that, and we wonder how couldn't we get higher, and we looked into that data. That's simply because the dispatcher only identifies 76% of the cardiac arrest. They miss 25%. So we work with that, more about that tomorrow on artificial intelligence to support the dispatcher in identifying cardiac arrest. This is a project we are running right now. Video transmission from the call to the call center from the citizens. We're also using that as a project in Copenhagen. It's for recognizing cardiac arrest, so that we turn on the smartphone video to the dispatcher so that they can see what's going on, so that they can advise people to do better CPR at scene, and also advise them what to do further on. So this is we use the good SAM for that, for the dispatch center. And then we also use civilian first responders, heart runners, different names for the same solution. Heart runners in Copenhagen, good SAM here in Australia, and in most of Europe, PulsePoint in US, and My Responder in Singapore. This is also very important. I can give some data on that, but that has been very successful. We recruited about 50,000 volunteers in Denmark for a population of about 5.8. We had 25,000 in Copenhagen. Begin AD programs and use smart technology. I already mentioned that. So we have that engaging the community, and we're doing that as a randomized controlled trial that can be discussed from an ethical point of view, but we want to document the effect there and to further implement it in other countries and other areas if it has the effect that we expect. But we are doing this as a randomized controlled trial. For the make CPR and AD mandatory in training in school, we just saw that you have that in all states in Australia. It is not that advanced in Europe. We have that in Copenhagen, have had that for 12 years now. It has a huge impact because it's a kind of culture of excellence change that we promote by doing that. And UK also recently, last year, implemented, or not implemented, but got to that point and said we want to do CPR training mandatory in schools. They were pushed by the Scottish community, and then they finally decided to do so. That is very nice. Other countries are also going that way forward, but only few in Europe actually did it until now. Working towards culture of excellence annual reports. The annual reports are important. We use the 10 programs to actually now as a template for reporting, inspired by New Zealand, by the report there. We also use and Victoria as well, because you have that in your reports, and we thought that was a very good idea. Use the assessment tool for reporting, we also do that. We don't have time to go through that, unfortunately, but I'll just say we use that system. It's for free in the GRA. You can sign up at the Global Resuscitation Alliance homepage or Resuscitation Academy, and you can get that report. I took that for the whole of Denmark, actually, and this is the total results we got. So the colored bars are actually registered telephone CPR dispatch system, high performance CPR and AD training is the Danish score we got. The solid black line is the average with those who actually signed up in the system and put their data in. And the dotted line in the upper is the top performance system in the system. So here you can actually compare. You also get some advice on what, for instance, for cardiac arrest, we got 83%, and you get some advice what to do, and you do that for the other ones as well. So it's a nice system. You can compare with system like your own, with population, whether it's rural or urban, and the size of the EMS system as well. And so it's going to be better and better the more system actually provide their information.
Vagtcentralen, det sygeplejerske Annette.
So this is just for the last slide, actually a movie how we recruited 50,000 volunteers to be first responder in our system. In our dispatch system, when we realize this is cardiac arrest, we dispatch these volunteers. It's done automatically, and in 40% of the cases, they will arrive before the ambulance services. So this is just a movie we had on the internet to recruit people, and it works well, and as you will see. Sorry, it's in Danish, but it's translated.
Vagtcentralen, det er sygeplejerske
But
Annette.
it's just about the sense there.
Jeg skal have en ambulance. Jeg tror, min mand er hjertestop.
Jeg sender hjælpen ud til jer. Den kommer hurtigt. Der er en ambulance på vej, og der kommer også hjerteløber ud til jer. Jeg kan se, at ambulancen er hastigt på vej til jer. Den kommer inden for få minutter, ikke? Så er der rundt.
Kommer muligvis nogen og banker på døren. En hjerteløber. Der er nogen, der er ude og åbne for dem.
And as you can see, we dispatch people. We dispatch people to private homes as well. So survival rate can be optimized. We have limited national data from Europe, but we have some excellent national registries having documented increased survival for the last 10 years. We have huge variations between countries and within the EMS organizations. We have a huge potential there within the GRA program. The key is in the dispatch, in my opinion, and we have a lot of ongoing research in Europe that we would like to share with others, just like you have in Australia and New Zealand. Hope to see some of you in Scotland for 2020, or if you can't go to Scotland, you can go to Paris or Berlin in the following years. Thank you very much.